Good afternoon, everybody. It's a little more comfortable this time. The room's not quite so packed, but still glad to see that there is so much interest in this topic, and certainly of interest to myself and my co-chair as we start this round. And what we're doing this time is that we are hearing from our universities and our centers of education and research in our state that are doing great things. Are on the cusp of beginning and have programs that they want to institute to do great things. And I'm going to start by asking Dean Jean Sumner, Dean of the School of Medicine at Mercer, if she'll come forward. And then, Dean, when you are ready, you can just call Dr. Warren up to do his part of the presentation. Thank you for coming from Macon. I have to present. Thank you. Huh?
Thank you, Madam Chairman and the committee, for allowing us to say a few words about what's going on at Mercer on behalf of maternal health in Georgia. Oops. Better? Okay, sorry. I think you know that we are focused on rural and underserved populations, but it will take every institution in this state to address this problem, and so we're here to help and work with everybody. One thing that we've done at Mercer recently, many of you have heard this effort, but we've established and committed to continue to establish rural health clinics across the state. We started in Plains, and we just opened in Peach County, and we will open in Clay County after the first of the year. Sumter County has 148 out of 159 in health status. Peach County is 112 out of 159, and Clay County has moved from 159 to 156 out of the 159 counties. And so we believe that establishing a basis of quality primary care in these counties is so important. So what we've committed to in each of our clinics is behavioral health services. We provide those largely by telehealth. Telehealth support for the doctor there. Sometimes as a local physician in a small town, you just want a second opinion. You can do that with telehealth. You also can bring in incredible consultation from experts in different fields to your office. And we'll have basic diagnostic studies. We've committed to laboratory x-ray, hopefully ultrasound, and we want to bring mammography to counties without mammography. Clay County, for example, has no mammography. Sumter County has mammography, but we do think that that's very important. But in every Mercer clinic, there will be women's health services. We've hired a OBGYN in Plains. She's there 3 days a week. She does great work, and we'll continue in that effort through these clinics. I think we also are focusing on maternal mental health. We know that's a major part of our issues in maternal health. And through the Innovation Center, we're offering mental health first aid courses to communities at no charge across Georgia. We're working with the American Academy of Pediatrics and ACOG to encourage screening. Dr. Jennifer Barkin will speak to you later. She developed the Barkin Index of Maternal Function, which is how effectively the mother adapts to motherhood, and that certainly affects the outcome with the baby. There's increasing evidence, and I'm an internist, so I'm sitting next to OBs, that mental health in pregnancy affects the placenta and the wellness of the baby. But that is a very important part of that. I know that Postpartum Support International has now established a chapter in Georgia, and that's an important organization. It's something that we certainly are interested in working on. I'm pleased to have with me Dr. Jacob Warren and his co-researcher, Dr. Bryant Smalley, who are working on a Healthy Start South Georgia grant that they will talk about later. But it really focuses on a comprehensive look at care for the mother and before pregnancy. One thing we know that early intervention matters, and my children, we're a non-smoking family. My children were impacted by the anti-smoking movement early in the 90s, and they would literally walk up to strangers in restaurants and tell them not to smoke. So it's important to look at that in terms of pregnancy and early wellness. Those children take that back to families. For the first time in history, the last 3 years, a baby born will not live longer than their parents. The Surgeon General was in Macon this week, and one statement he made that was impressive to me was that 70% of Georgians cannot pass the physical requirements to enter the Army. And so if that's the case, we're in trouble because some of those people will become mothers. I'm an internist. We like to think of ourselves as the people who gather that comprehensive history, and I've done a lot of histories on patients and always felt like the Sherlock Holmes. You know, I'm sure all doctors do that, but we go to the nth degree to gather data on that patient. But I was never trained to say, are you planning to get pregnant this year or next year? We never got that. I learned it, but it's something that we really need to look at. Imagine walking into any drugstore in Georgia and there's a sign that says, are you planning to get pregnant next year, with a little flyer that says some things you could do, because mothers are motivated. Mothers are motivated to take care of their children. Prevention is so important. And again, the Surgeon General this week pointed out the need for prevention, but he also talked about our vaping, the acceptance of drug use, and he particularly was interested in the normalization of marijuana for young people, particularly pregnant mothers and its adverse effect. And he talked about the need for local care. I don't think there'll ever be a day in Georgia that every county has an obstetrician that has a practice there. I'd like to think so, but I've been to a lot of counties, and it's going to be hard to achieve that. We may not achieve that doctor in the county, but we can achieve care in the county. And through the Healthy Start grant, we're working with Memorial out of Savannah in a pilot to get approval through the ACGME and the OB Residency Review Committee to approve those residents going into these terribly underserved counties and the attendings overseeing them real time through telehealth. According to what I've been told, that's the first time in the nation if they approve that. We haven't gotten the final approval, but I hope that will happen. And certainly we can bring services into some of those poorer counties periodically, rather than loading pregnant women up and driving them 60 or 80 miles. I think most of you know we're very honored to house the Georgia Rural Health Innovation Center. It's a center for all of us, so if anybody interested in rural health, we're welcome to work with us, and we'll work with you to improve our state. The one thing I want to make sure that I say is rural is different, it's complex, and it's challenging, it's not easy, and it's hard to get the kind of data you need and to show what the problem is. One statistic, and I can quote many, is that rural teens have a much higher percentage of pregnancy than suburban teens. We should be able to address that. If you look at this map, you can see, even in Georgia, the areas where there are the fewest physicians had the highest low birth weight babies. We need physician-led care and team care in those counties to make a difference. The data is so important to all of us. It has to be, I appreciate the work you've done as a legislator to increase transparency in healthcare, but we need transparency in data. Data needs to be accurate, it needs to be county level. It's very hard to find quality data in rural communities or to gather quality data, and we're making an effort to contribute to that and to make it available to any researcher or any organization that wants to use that data to better the state. So county and regional level data is critically important. You use that data to identify a problem, you design an intervention, you restudy that, and maybe you come up with a really good solution, or maybe you just start over. But nevertheless, it leads to sustainable quality health care. One thing we'd like to offer through the Innovation Center is a rapid strike team for rural Georgia health issues. We're very able to respond to you immediately. If there's an area that you need information on, if you'll let us know, we will be out there trying to gather that data or help you. We're available to offer assistance with the community needs assessments so that these communities realize the problem they have with maternal mortality and infant mortality and maternal health, and try to guide that process. But we can go out and gather specific data or identify. There's so many experts in Georgia, not just at Mercer, but across the state, that sometimes it's hard to realize that the experts are here with us, and we need to identify that group that can be available to you as you guide the state. We know how challenging it is to obtain, but we can no longer afford to take resources and scatter them across the state. Those resources need to be used in a precision manner to address specific problems, and we want to contribute to that. As you go through your deliberations, I know it's easy to look at rural and urban together, and the rural data is really strikingly worse many times than the urban data. But it's often because the most of Georgians live in the metropolitan Atlanta area, it's easy to craft a plan that works. And one example for that, I would say, is the immunization rates in rural areas are historically always lower than in urban areas. There are a lot of reasons. One is trust. One is lack of education or information for the people who need the immunizations. But several years ago, I wrote, with some others, a grant to work with private OB guys, public health, and family medicine doctors to take care of mothers who were indigent. And I was, even though we weren't funded, the attitude of the private obstetricians impressed the hound out of me because they were so willing to work with family medicine and people to get mothers care, that because they were delivering the babies without care. So they were willing to work with public health and offered to do anything. I called some of those guys in the last week or two just to see what was going on with them and see what their problems were. And one thing that continually came up was they need to give, a Medicaid mother comes into them and needs immunizations. The bureaucracy of Medicaid is often so great, and the cost, the reimbursement so poor that they can't afford to give that immunization. The Tdap is too expensive. They said, we'll break even. We don't need a profit on them. We just can't lose money every time we give an immunization. And so look at those reimbursement rates and the bureaucracy, because immunizations matter in pregnancy a lot. It protects the mother. It protects the newborn. So thank you for all you do for our state. My goats have nothing to do with y'all. I just thought I'd bring the picture. I'm pleased and honored to introduce
Your goats?
that was my chicken. That's my neighbor's goats.
Oh, okay.
Well, I'll get you one if you need it. Deborah Stokes is with us today, who's the executive director of the Innovation Center. I think most of you know Deborah. We stole her, and that if you wonder where she is, she's in Macon and doing a great job for the Innovation Center. And I'm pleased to introduce Dr. Bryant Smalley and Dr. Jacob Warren. Dr. Warren will present on their Healthy Start grant. So thank you very much for the opportunity.
Thank you, Dr. Sanger, and thank you for everything that Mercer is doing. You're certainly leading the way in our rural areas, and I'm glad to hear that at each one of the clinics that you're opening, you're going to, I guess, you have one now, and have two, and each one will have a women's health, so they will be able to prenatal care and work with the women.
We opened Peach County October 1st, so we have not gotten women's services there, but we will. We'll open Clay County probably after the first of the year. We hope January or February. We don't know yet because it depends on construction, but the good thing in Clay County is we're going to co-locate the health department in the facility where we are, so it'll be us and the health department, which I think will be great, a great experience.
And one of the things I hear all the time, like from the federally qualified health programs and others, is that they don't have any budget for letting people know what they do and where they are. How does Mercer let people in these counties and surrounding counties know that they're there and that women's services and for prenatal care, how do they let people know that? How does Mercer do it?
We become part of the community. You don't get very far in a small town if you aren't part of the community. So I can tell you an example is Charles Duffy, who runs Mercer Medicine, came in on a flight the other day, and he got to Atlanta about 3, and he drove to Plains. And I said, how did you get in the little bed and breakfast? He said, they left the key on the pot on the front step. We're members of the chamber. We show up for meetings. We let them, you can spread the word in the rural community. You have to earn trust from local people, and that word spreads rapidly. And the example is Plains. We were booked. We actually had to back off our appointment book because we wanted to be able to do walk-ins, and we were booked for 3 months when we opened. So it's about being there and staying there, and if they know you're coming for the long haul, we're there. We're not going. We need an invitation, and we have to have community support, and so we do that to get patients. We have not had a problem getting our name out there.
But Dr. Sumner, the chamber and everybody and the people, I understand that, but how do you reach people that are maybe in a lower financial, socioeconomic background that don't belong to the chamber? You know, are you reaching out?
You know, Madam Chairman, I understand that question. You go through communities of faith.
Okay.
You know who the community leaders are. And I'll give you one specific example. We did an osteoporosis screening day in our little community. There is no newspaper, radio, or television station that people in Johnson County look at consistently. So we put it in the church bulletins.
Okay.
The first day we had 272 people. It looked like we were giving away something free. We weren't. You have to understand rural. It's a little different, but it's trust and being part of the community.
Representative Hughley, do you have a question?
Yes, thank you, and thank you for what you all do at Mercer. One of the things that you said that struck me was teens in rural counties. So why is it we don't have a program to promote health for girls? Because if we're waiting until they're adults to promote healthy mothers or whatever, some of them have already become mothers, it's particularly in rural areas. So are you all doing something particular to promote health among girls?
We don't have a specific program, though I have some ideas. I'll be glad to talk to you about them sometime. I think there's so many opportunities. You can move the needle in a rural community sometimes easier than an urban community if you get leadership involved and young people involved in that. So again, it goes through the unusual channels, but once you're there and build that trust and have the type of providers that reach out and engage those young people, I think you can do that.
Thank you. Oh, sorry.
Just one other question, and of course, we all know about the disparity in maternal mortality for women of color. So in your rural areas, are you all doing anything different or particular?
That's
How
the
are you all doing
perfect
that?
lead-in for Dr. Warren.
Okay.
Okay.
Yes and yes. So we're excited about the potential of this, and we're excited about the potential to actually bring OB residents to some of these counties that haven't seen that in 50 years. So
Thank you. It's nice to see you again.
And I see you again as well. And thank you for that excellent lead-in. That's
It was.
exactly what we're about to talk about, so thank you. So thank you, Madam Chair and members of the committee, for the opportunity to talk to you about what we see happening in rural Georgia in particular. There are some very unique dynamics at play when we look at maternal health issues and maternal mortality in specific. My name is Dr. Jacob Moore, and I'm the director of the Center for Rural Health and Health Disparities in the Mercer University School of Medicine, where I also serve as the Associate Dean for Diversity, Equity, and Inclusion. In the Center for Rural Health and Health Disparities, our purpose is to partner with rural communities to develop, implement, and test novel solutions for health disparity issues. So that's why we exist, and that's what we're focused on doing. So I'm going to talk to you a little bit about what we see happening in rural Georgia and how it compares to the rest of the state, some of the main challenges that lead to those disparities that we see between rural and urban areas, and then some of the solutions that could be put in place, and then specifically about our program that we're doing to address exactly what you were asking about. As you know, and the reason we're all here, we have a maternal infant death crisis throughout the entire country. The maternal death rates have more than doubled in the U.S. since 1987, and the U.S. currently ranks as 46th in the world in maternal mortality. That places us behind every other developed country in the world. Within Georgia, as you all know, there have been several reports to come out that name Georgia as 50th in the nation, so having the highest maternal mortality rate in the country with the highest maternal mortality rate in the developed world. When we start to look at what's happening, there are layers of risk that exist for rural women in particular. Rural women in Georgia, and I'll show you some data in a moment, have a significantly higher maternal mortality rate than in urban Georgia. And at the same time, as you mentioned, we know that rural African-American women have significantly higher as well, or African-American women in general throughout the state. In rural, the risk is doubled. So rural African-American women face double the maternal mortality rate of rural white women. But when we start to look at how these layer, this is a graph that shows you consistently over time, we have seen this rural-urban disparity. It's been around a long time. But when we look at layers of risk and what particularly happens when we compare within both rurality and race and ethnicity, you can see how the disparities are present. So rural African American women actually have a 30% higher maternal mortality rate than their urban African American counterparts. And so there is something unique and contributory in rural that is placing even higher levels of maternal mortality risk upon rural African American women. When we look at rural white women, they actually have a 50% higher maternal mortality rate than their urban white counterparts. So there is something really profound and systemic happening in rural Georgia that we really need some innovative approaches to address. When we think about, generally though, these layers of risk, we do tend to focus in on demographic characteristics. We talk a lot about race and ethnicity, we talk a lot about geography, about income, age parity, these demographic characteristics, but there's nothing inherent about being a woman who resides in rural areas that increases your risk. It's about these associated factors. So when you look at resources, the general resources that are available in a community or to a person of color, if you look at access to care, when you look at the social determinants of health, this is what's driving these disparities that we see. So when we have these differences across these areas, they interconnect, they intertwine, and it's very complex. I'd love to come up here and say, this is the one thing we need to do to address this in the state, or the one thing we need to address in rural, and it's just not that simple. So I want to go through each of these layers. These are just a few things that are important, but these layers do relate back to fundamental barriers to healthy outcomes. When you look at rural residents in particular, they face increased burden in accessing support services and health care in virtually everything that you can think of. Transportation is something you'll hear anyone talking about rural health be one of the first things that comes out of their mouth, because we do not have public transportation, and that is a substantial barrier to accessing any type of support services, health care included. There's also increased rates of shift work, where it's much more difficult to get time off, particularly if you're having to travel 70, 80 miles away to access services, where you have to take an entire day off work. You might not be able to afford to do that, even if you are able to get permission from your supervisor to get time off. Their lack of supportive organizations. There are many tremendous agencies here in the metro Atlanta area working on issues of maternal mortality. We don't have equivalent agencies throughout rural Georgia. There are also distinct differences in the accessibility of social services and the ability to access those that are available throughout the state. What this leads to is differences in baseline health for women before they become pregnant, and then differences in accessing adequate prenatal and postpartum care in rural Georgia. When we think about access to care in particular, and this is pretty telling of why we have the issues we see in rural Georgia, 93 rural Georgia counties have no hospital with a labor and delivery unit. There are only 27 rural counties that actually have a labor and delivery unit in the hospital that's present, if there's a hospital at all. Even more troubling when we look at the trends in maternal mortality and how this has been increasing in recent years, 43% of all rural labor and delivery units have closed in the past 20 years. So we are at a profound inflection point in what's happening here. 2/3 of rural births as a result of this must take place outside of a mother's home county, because there is simply nowhere to deliver locally. And it's very easy to see how this impacts maternal outcomes. In addition, there are no rural counties in Georgia that have a high-risk OB, Society for Maternal and Fetal Medicine specialist. You must leave your county to access high-risk OB services. This is obviously a direct barrier to receipt of prenatal care, high-risk OB services, and postpartum care. So the labor and delivery process is not the entirety, of course, of the pregnancy experience, but the system that surrounds labor and delivery also disappears when the labor and delivery unit closes. So the OBs leave because they go to another hospital that does have a labor and delivery unit. The ancillary services that surrounded that OB also leave because the OB is no longer there. So it's a cascading effect in rural Georgia when you have a labor and delivery unit close. It affects the entire continuum of care. It also prevents the establishment of continuity of quality care. So if you are a rural woman in a county that doesn't have an OB at all, much less a labor and delivery unit, you'll have your initial care from your primary care provider. Then you have to go 1 or 2 counties over to access an OB. Then if you end up in a high-risk pregnancy, you have to go 3 or 4 more counties over to access that high-risk services. And so your pregnancy care has been scattered across 3 providers throughout the state. And ensuring the continuity of quality care in that process is extremely challenging. In the broader perspective, this happens in the context of having lower access to preventive care in the first place and to primary care in the first place. If there is a crisis that occurs, there's greater EMS response times, there are fewer ERs that are local, and there's a greater distance to hospitals when postpartum emergencies occur. So all this contributes to some of the unique disparity that we see when we compare rural to urban. One thing I do want to point out that affects all populations, but it does impact rural women particularly hard, is sort of a myth that I hear sometimes around Medicaid coverage, or a misunderstanding really might be another way to state it. So it is a fact that more than 50% of births are covered by Medicaid, and so Medicaid policy really shapes women's health in significant ways. But there is a widely held misconception that this meets all of pregnant women's needs. So there's sort of this concept that we have right from the start, and so that's covering everything that women need. And right from the start is an essential program. I don't want you to hear anything else from me. It is absolutely essential. But when you look at coverage guidelines, right from the start coverage ends 60 days after birth, sometimes shorter depending on your CMO. Current American College of Obstetric and Gynecology guidelines extend the postpartum care period to 90 days. So their last recommended postpartum care visit occurs outside the right from the start coverage window. And so that's obviously a barrier to accessing adequate postpartum care for women who are on right from the start. In addition, the pregnancy period is not the only time that affects pregnancy outcomes. And so if a woman is on right from the start because she's been uninsured the 18, 20, 25 years up to the point she became pregnant, you can't ignore the effect that having been uninsured all that time has on pregnancy outcomes. So yes, right from the start is essential, but it doesn't cover everything. That's the main point I wanted to get across there. So social determinants, it's going to pain me to do this in about 30 seconds because this is something this committee could spend a year really getting into the intricacies of how this affects maternal mortality. But when you consider how it affects rural women in particular, we all know about the rates of rural persistent poverty, so the economic stability components of social determinants particularly hit rural women hard, education levels, social community context, how they access the healthcare system, neighborhoods, built environment, all of these factors we talk about in general with social determinants impact rural women even harder.
Just a little bit more than
Sure.
30 seconds.
I'm glad to.
I mean,
Feel free to cut me off when I go too far.
Like social and community context and neighborhood, and we understand about economic instability and that, but
Sure. So when we get into the social community context, part of that refers back to the broader system of supportive services that I mentioned before. So having local agencies that are tackling these kinds of issues, if those support systems aren't in place, that's a direct access issue.
what do we have in the metro area that they don't? I mean, like access to healthy mothers, healthy babies, that group that works so
Right,
hard.
or NGOs, local agencies, nonprofits. There are a lot of tremendous agencies here in Metro, and just the dynamics of rural, we don't have the same access to that. Other aspects of social and community context are, there are issues when you look at racism and discrimination is something that does occur not just in the healthcare setting, but in the broader environment. So, there are lots of evidence that 80% of African Americans experience discrimination directly in the healthcare system, but it's the broader system as well that impacts things. So all of those factors come into play. And for rural women, there's also rural individuals in general, accessing care in an urban area is something outside of a lot of people's comfort zone. You'll hear a lot of people say, I don't want to go to the city. Because there's just this dynamic, and people are experienced differently who have come from different backgrounds. So when we think about core issues in creating solutions to the maternal mortality crisis in rural Georgia, there are three issues as we see them. Three core issues. There are a lot more than this, of course. And number one is, what do the data say? And a lot of attention has been paid to that in this committee. How do we help women now? And then how do we create broader systems change to affect the underlying issues that we see? So in terms of what do the data say, I'll just rewind to last session and press play for y'all for a couple hours on this issue. The interpretation of maternal mortality data is complex. I'll just put it that way, especially when you're approximating cause. So it's very, very challenging to do, as you know. And as a result, MMRC results typically lag behind other sources of data. So one thing that we end up having to do in rural communities, because we don't really have other options, is we must rely on the data sources that are available. We recognize there are limitations that are involved in those, but if we wait until official MMRC results are here, as you know, right now we're 5 years behind. And so if we don't at least look at what the other death certificate data are saying could be happening, not saying that those are firm results, viewing it as preliminary evidence of what might be occurring, it allows us to respond more quickly. If we see a sudden spike that we can't relate back to some data quality issue, it could indicate there's something happening that we need to pay attention to until we can get MMRC results in. I'm very pleased that part of this has already happened, so additional support being provided to MMRC to speed up the response process is very critical, and continuing that support will be important. But when we move into how to help women now, there is an immediate need for initiatives to support women throughout the state and in rural areas as well. So for populations that are most at risk for maternal mortality, which for our state is African American women and rural women. Barriers do currently exist for providing full support. We have great programs that are out there, but as I mentioned, right from the start, for instance, the cutoff there is a challenge. So solutions that could be put in place: expanding access to case management and home visiting programs. I'm going to show you how we're already doing that in the Center for Rural Health and Health Disparities at Mercer. Another solution is to expand right from the start coverage to that 90-day period. Adding on that additional 30 days allows women to access the full ACOG recommended postpartum visit period. Ideally, of course, I'd like to take it up to a year because that covers the full maternal mortality period. If we can provide care till then, I know everyone would love to do that.
Well, that's what I'm asking for.
Yes,
and
well,
I think everybody on this panel would push for a year.
That would really directly address the issue. Another solution that's out there, Planning for Healthy Babies has been a tremendous program, and I really want to commend the state for starting it and for continuing it. It has been very, very important to women throughout Georgia. But the way it's currently structured, when you look at the interpregnancy coverage period, that only applies to women who have a very low birth weight baby. And so we're using that to cover planning for healthy babies, but we could also use this as an opportunity to plan for healthy women if we extend that IPC coverage to women we know are at risk for a maternal mortality outcome. So right now, you could have a woman who was covered by planning for healthy babies, who goes through pregnancy, was preeclamptic, and then is dropped because she didn't have a very low birth weight baby, even though we know that woman is at direct risk for a negative maternal outcome. And so if we can extend Planning for Healthy Babies to cover women that are at documented risk for maternal mortality, that could really go a long way.
We need to put that in the recommendations.
So then in the broader context, how we change the fundamental system, and this gets a little more specific in rural versus urban. So the solutions that we need in rural Georgia aren't the same ones that we need in urban for how we fix the systems of care. So rural Georgia must have new models for delivery of prenatal and postpartum services. 43% of our labor and delivery units have closed because that traditional model is not financially viable in rural communities. So we have to have another way to look at this. And then we need associated policy changes to support those models. So I have additional examples of these. We placed them in the packet that was given to you, but the ability to explore strategic placement of tiered services based on local need and integrating those into prenatal systems of care, where even if you are having to travel a few counties over, it's all interconnected into one system and we can ensure that continuity of quality care would really go a long way in rural Georgia. And looking at how we strategically place additional services could really support that.
Would you give me an example? Can you give the committee an example of that?
Sure.
How that might look?
For example, I won't go back to the slide because I'll get it messed up, but there are several counties in Georgia, Tolliver County is one of them, where there's not even a labor and delivery unit in a surrounding county. And so if we place either community health workers, a certified nurse midwife, someone there that can be a stopgap coverage to at least provide some level of access to care and is interconnected up to an OB in the neighboring county, et cetera, just to get something more local. Of course, supported through telehealth would be the ideal way. And then a second solution here is creating a billing pathway for maternal child health focused community health workers. 20 states have community health worker program certifications. And so if we do something similar in Georgia, that could provide a pathway to billing for evidence-based outcomes.
Neil? Okay,
Yes.
well, go. Okay.
Could you give an example of what you're talking about, the community health worker? Are you talking about an LPN, somebody to work with expectant mothers, something like that?
I'll talk a little bit about that in the next part where I'm talking about our Healthy Start program,
Okay.
but the traditional model of the community health worker is a lay person, where it's someone that is a member of that community and has local connections and local support that is then able to affect women in a uniquely local way.
And lives in their community.
Yes, lives
so
in
that
as a
they
part of the community.
So they're more likely to feel it comfortable with them and all.
Exactly.
Okay. We have another question
Yeah,
for you.
a quick question. All our counties are crucial and valuable resources, but they are pretty small in Georgia, some with as little as under 2,000 people, and some with as little, I think I was looking it up, 8 or 9 people per square mile, which of course could never support a real hospital, much less an OB
Right.
and a full maternal fetal medicine or backup and all. Has the Center for Rural Innovation started to look at regions, and if you do you look at the amount of time it takes to drive in a region, or how can we look at this rather than necessarily try to fix something for every county? We know that's not really rational or necessarily achievable. Is there a way to look at the state to where these rural areas are kind of grouped and say, what's your target for how close you want to be to a place to deliver your baby? Especially when you're, like I say, under 10 people per square mile in large groups of counties, and maybe like Talifer and the other ones around it. Is there an effort with that Rural Innovation Center to look at regions?
I know there's some regionalization in that center. The center that I direct, we're working on similar issues, particularly with maternal health, because that's one of our major focus areas. And a lot of it is driven back on that map of the size of the county and the proximity to other care. Because I can't remember if I mentioned it before, the other issue with placing full services in each county is then you further destabilize the labor and delivery structure that has managed to reach equilibrium. And so there is a way to look at access points.
One more question before we let you move on. Representative Stovall.
Thank you, Madam Chair. Recently, I was at our Georgia Women Caucus retreat, and we actually were talking about maternal mortality and some of the things we could do as a state to try to prevent it. And one of the topics came up from one of the doctors that was doing pre-planning before women even get pregnant. And what they found was that a lot of the women were diagnosed with different kind of health concerns, whether it was high blood pressure and all of that, but they were not allowed to treat them for that. The patient would have to make an appointment with another doctor to come to be able to treat for that. And what their suggestion was, while they have them there, the women there, why not being able to allow them to treat them for those diseases or whatever the cases may be, being that they probably will end up maybe becoming pregnant, and that could be something that could be preventable. So I would just like to hear your take on that part.
Yes, I completely agree. So it sort of goes hand in hand with what I mentioned about if we extend planning for healthy babies for women at risk after delivery, the same thing if we can broaden out the coverage that is available in that initial period where it covers more than women's health issues. If someone does come in and can have their uncontrolled diabetes treated, can have their uncontrolled hypertension, because even in the planning for healthy babies context, that impacts infant outcomes as well as maternal outcomes. So yes, it'd be an ideal solution, I believe.
Okay, go ahead.
So I'm really excited now to talk to you about what we're actually doing to address this. You get kind of bogged down sometimes in how upsetting the statistics are and what is happening out there that needs to be addressed. And so I want to talk to you about South Georgia Healthy Start. So I'm here along with my colleague, Dr. Bryant Smalley, and we direct this initiative that is funded by HRSA. And so this is our acknowledgement slide. So we'd like to thank HRSA for funding this. And these views are ours and not the views of the federal government. So what we're doing in South Georgia Healthy Start is we have brought together a group of communities that is working to eliminate disparities in maternal and infant mortality in 7 rural counties in Georgia. So we're working in Appling, Bullock, Candler, Manuel, Jenkins, Tattnall, and Toombs. And so it's these orange counties here in the state. One of the questions earlier was about how you get people to know about the services in your community. We've been working in this area through the Center for Rural Health and Health Disparities for over 10 years. And so we were able to implement programs like this because we already have an established presence, existing partners, trust, buy-in. We're able to work on this type of program. So through South Georgia Healthy Start, we serve 700 women, men, and children per year. It's a 5-year project. We're funded through 2024, and it's funded through HRSA's Maternal Child Health Bureau. So HRSA provides funding with this. We've also received additional support for other projects from NIH. I failed to mention earlier that our Center for Rural Health and Health Disparities is one of only 2 centers of excellence in the entire country focused on rural health issues. So that lets us work on a lot of this. So I do want to show you some data when we look at what's happening in rural Georgia and in this service region, and part of why we're working there. Some of these numbers are up for discussion, but the generally accepted USA maternal death rate is around 18. For urban Georgia, we're looking at 55, and in rural, 69. But when we look at this 7-county region, the maternal mortality rate is 85 overall. For African American women in our service region, it is a shocking 132. And so when we look at comparison points, the maternal mortality death rate, or maternal mortality rate, is 68 in Syria and 82 in North Korea.
What year is this? Is it for 1 year?
This is, yes. Well, this is the rate per 100,000 births.
Okay.
So this is the rate.
Okay, for 100,000 births.
For 100,000 births, the number
Okay.
of maternal deaths, yes.
For each region, so the 132 per 100,000.
Yes.
Okay. Which would take several years to reach, wouldn't it?
To reach that mark, yes, the rate is far accelerated. We have more deaths in metro areas
Right.
because there are more people, but the
Right.
rate is much higher in rural. So we're focused on 7 areas of activity within South Georgia Healthy Start, and I'm only going to go into details about a few of them, but we do provide direct clinical care. We provide extensive case management services, comprehensive health education. We're doing a lot of community engagement work, workforce development, policy change, and research. Complex issues require complex solutions, and so that's what we're doing. We're trying to address everything from can you get in to see a provider, all the way up to what are the policies that we can change that are barriers to your successful pregnancy. So on the case management side, what we're doing is providing risk-based service tiers based on the general mortality risk. We provide regular check-ins where our case managers routinely check in with women to see what barriers they may be experiencing and how we can help them work around those. We do provide home visits. The frequency of those depends upon the risk tier, but everyone receives at least one prenatal visit and one postpartum visit, so someone going out to the home to actually assess how mom is doing in their location. One of the core characteristics here that gets at some of the biggest issues we have with maternal mortality is we're providing support to women from the time before they become pregnant all the way up to 18 months postpartum. And having that type of comprehensive set of services is really how we help address this issue. In terms of policy change, Dean Sumner already mentioned this, but we're working with ACGME to grant what we believe is a first-in-the-nation waiver that will allow OB residents to rotate through rural areas that don't have OBs. So with the level of medical education we have in the state, there's a significant barrier right now to accessing OB residents to send out to rural communities. The goal is there's not an OB there, let's send out a resident. But current policy says they cannot go out to that site unless there's an OB on site. Well, if there's an OB on site, we don't need to send the resident to the site. So we're trying to work with ACGME, and they've been very supportive in this process to say, can we just do the supervision process through telehealth? It's not that there won't be a supervisor present. You can have live supervision via telehealth. You get the same level of service. You have that immediate access up to an OB or even an MFM if necessary, but just let us do it through telehealth. And they've been very supportive in this process, so we're working on getting that rolled out as a demonstration project for ACGME that could then end up changing the policy nationwide. On the research side of this, part of the complexity, as you know, with maternal mortality data is we're always looking backward. And so we're trying to figure out what happened after something has already occurred. But through this program, we'll be following 700 participants each year. We follow them for a 3-year span, and we're doing this for 5 years. So we're going to have thousands of women participate in this program that we're going to be able to prospectively look at what were the predictors of maternal mortality, severe maternal morbidity, low birth weight, negative infant outcomes in a prospective manner, which is very critical to really understanding what's happening. So this really will let us have a unique opportunity to really robustly examine maternal and infant mortality.
Did he push his button? Yeah, okay.
So I do want to wrap up quickly with our vision of the work that we're doing. We do want to achieve, like everyone I'm sure, but a Georgia where all mothers and babies survive and thrive, regardless of your background, regardless of where you live, regardless of your race, ethnicity, anything. Whoever you are able to survive and thrive. So thank you again for the opportunity to come and talk to you, and I'm happy to answer any questions.
Dr. Ray.
Thank you, Madam Chair. Just a couple of quick questions. One, regarding the data that you give, the numbers don't seem to match up with the data from the most recent Maternal Mortality Review Committee data.
Right.
For urban Georgia, 55 per 100,000, rural Georgia, 69 per 100,000.
Yes.
I mean, is this pregnancy-associated maternal deaths?
These are pregnancy-associated maternal deaths, and the reason for that, again, is these are more recent data than we're able to access from MMRC. So what I would look at there is the proportionality, because in general what we see is even though the numbers might shift in their actual magnitude, the relationships of those numbers across those different groups remains pretty consistent after MMRC review. So if I'd put percent changes in here, it might have been more illustrative for you, but the magnitude of difference between the groups is fairly consistent from pre to post MMRC review.
Okay. I mean, for my own sake, I think the care in identifying that given this data, I think it also is something that I see often, in that the data is very misleading when it's put this way, as pregnancy associated, not pregnancy related, for one. And when I see a lot compares Georgia to developing countries, and my question is always, are they counting? How accurate is their data? If we're not comparing apples and apples with everything, I think that's the point. And to the detriment of MMRC work, if it's not apples and apples, I think it's challenging to get data out unless an MMRC gives the data that we compare to our own MMRC. And the other thing is what's the volume in the service area for which the data is captured here? So when Madam Chair asked the question about how is 132, from what I know now, is pregnancy-associated maternal ratio.
Yes.
This 132, what's the volume for deliveries in the service area for which generated that number?
We have about, in this region, we have about 2,300 births per year in this 7-county region.
2,300 births. So how many
Okay.
deaths then did it? I mean, with that low volume, how many deaths would that be? Absolute number of deaths would that be to generate 132?
I don't have that data point with me. But again, what I would encourage everyone to look at is this is not a blip. So if I present these data over time, you'll see the same rough magnitude. So it's not that we suddenly had 1 or 2 extra deaths in this year that spiked the maternal mortality rate because it's so sensitive with being low numbers. That's a definite issue with low count. But when you consistently see that,
But what we're here to do is to find out the ways to prevent the 60% of deaths that are pregnancy related. So if it's directly related to the pregnancy and it's preventable, that is, we've consistently seen that's 50 or 60% of the deaths. So it is misleading if you're talking about I'd love to see an absolute number, because if this is 4 maternal deaths in a service area over the course of a year, that's 2 deaths we could have prevented. I would like to know why. And so from maternal mortality review, that's what I'd like to see as far as how can we prevent that. Everything that you present as far as, I really appreciate the efforts that you make in rural areas, and I really love the idea of having an area where you can actually track this prospectively, because I do think you can make a very good impact as far as what you're seeing in an area such as this, especially from a rural standpoint. But this data is very misleading.
if I could comment, there are a few sort of philosophical approaches that you can look at with these data. One, I would love to present to you the rural-urban MMRC data. The data aren't released in that way. We're not able to access that to give you that
It was released in
information.
2012 and hasn't been released that way since. And the reason I know this is, 1, I just looked, and 2, I'm on the MMRC. So
Right. And so I can't provide you what I'm saying is the current picture. And so I agree with what you're saying. If we're saying pregnancy associated, yes, pregnancy associated. But there's even a philosophy in terms of the preventability of maternal mortality. So if we're talking about a direct result of hemorrhage complications, and that could have been prevented, it depends on the broader system. So we could take a broader perspective on the preventability of maternal mortality, because if we had addressed issues related to access to care that led to the hypertension, that led to the negative outcome, that's, depending on how you look at it, that's also a preventable maternal death. And so I do think that pregnancy-associated deaths do provide a very important perspective as well on the broader system of what's happening. So I think it's important to look at both.
to be clear, when we capture pregnancy-associated deaths, that could be someone who's hit by a car or has a car accident and dies not of their own fault. So pregnancy-associated numbers can be skewed significantly by accidents or things that are not directly related to pregnancy, hypertension, comorbidity, anything like that, just for clarity.
Right, but additionally, for clarity as well, if you look at the overall death rate among women who had a baby within the past year, it's higher than for women who didn't. So there is still something occurring that drives up the mortality rate in that period.
When you come explain it to legislators and people on our panel, you just have to make it simpler, I think, and maybe present both of them.
Well, again,
because
I
it's-
can't present these data because the counts are so low, the data are suppressed by the state, and so I can't exactly give you the data for this.
I mean, the accounts of maternal mortality is so low.
It's considered suppressed, yes. So once it drops below a certain count, and that's a systemic issue with rural health research, I can tell you. My
Okay.
little soapbox with rural health research, that the data are suppressed because of small counts.
Okay, Representative Hughley.
Thank you, Madam Chair, and thank you for your presentation. Can you tell me if Mercer is doing anything with its medical students on the issue of inherent bias, so that women of color can be heard when they interface with their doctors and that kind of thing? Tell me what you're doing on that.
Yes, I can actually speak to that directly because I give that lecture to the med students. So we have within our medical curriculum, we did a recent revision, and in it we built in an entire course that's called Population Health and Medical Research. We call it FEMR, of course, because it's a med school. We have a funny med school pun with it. But in that we have a very specific focus in the first half of their first block of med school that is a 4-lecture series on health equity, on implicit bias, on explicit bias, on racism in the healthcare setting, on how we interact with patients and how you need to listen appropriately, on cultural competence, cultural humility. We give a very intense focus to this issue in their very first weeks of medical school to ensure that it's undergirding everything they learn from that point on. And then we also have continuing lectures, continuing workshops on those issues throughout their entire curriculum. Yes, ma'am.
One other question, Madam Chair. You spoke about, when you were talking about rural residents and the resources that they have, and particularly women who are pregnant and working. Have you done any research as it relates to accommodations for pregnant workers in rural areas and how that may or may not affect the pregnancy outcomes?
I can't speak to that. I don't know if you can. Not directly of what's been done. The main barriers we see anecdotally in working in the communities is that high level of shift work, where just not having paid time off or not having the ability to adjust your schedule in a way that gives you the full day off of work to go seek care is a challenge.
So let's say a person is working in a, I know they have some chicken processing plants in rural
That's the
areas.
example I almost gave, yes.
And if the pregnant worker needs to have more frequent breaks or something like that, is that happening, or is that affecting outcomes or anything?
I can't speak to that. I'm sorry.
Okay, thank you.
Okay. That it? Any other questions? No? Thank you very much. And thank you all for coming. Thank you for all you're doing. Okay, that's it. Okay. Dr. McRice, you're up, and for Mercer School of Medicine. Thank you. Pardon? More. Why am I? Oh, sorry. I've got
I'm from
Mercer on the
Macon,
brain.
and so I will claim Mercer also, but
Yeah.
today I'm going
sorry.
to be representing. That's okay.
What is Mercer orange and black? Oh, see, that's what threw me off.
Yeah, I'm
No,
from Macon, that's right. That's right.
Okay.
Yeah.
I'm sorry, Dr. Wright. Let me tell you right before, yesterday,
Yes.
I lobbied the governor's office to get the $500,000 back from Mercer. I mean,
Okay,
back
good.
from, I'm going to do this, Morehouse.
Morehouse School of Medicine. this
I'm
is
gonna
it
get
over
it
there.
back.
Okay, that's all.
And this is really terrible. One of my good friends, Dr. Mitchell Lee, works for you. So,
That was and she was my mentor.
so
So
I am
she is
so
the
sorry.
reason that I am partly a reproductive endocrinologist and fertility specialist. And so thank you, co-chairman Cooper and Newton. Thank you all, and thank you committee for caring enough to always listen to us and understand what we can do collectively to make a difference. Representative Hughley, let me answer one of your first questions that you asked about what are we doing to help young girls and young boys along the pathway of their sexual development, to understand what maybe they need to do with their about health. We ran a program called From the Children's Aid Society, the Carrera program, to delay teen sex in Georgia and to prevent teen pregnancy from 2012 to 2017. Dr. Mary Langley ran that program out of Lumna, Fulton, and Jasper County. We enrolled 220 subjects in the 6th grade to the time that they graduated, and compared them to 180 students who were in the Boys and Girls Club. And they had a health and sex education program in school and after school in partnership with the Chamber of Commerce and other grassroots organizations in that county, along with their parents. And we are happy to report, the paper was published last year, that the young persons who were in that county, who had after-school programs, career development, lots of different activities, and we were really trying to focus them on graduation, had a 60% decrease incidence of ever having sex by the time they were 17 years old. And out of that 180 students, 0% pregnancy. And so there are things that you can do with young people that can help them understand about abstinence and what works for them in their life. And we're very proud to say that we have now recently done a part of that program in Sumter, Doherty, and Randolph recently with the Teen Summit down there a couple of months ago, and we'll be continuing that program. So,
Congratulations. That is a major findings, and thank you for repeating that program in other counties.
yeah, so
I
it
wish
is.
you could do it
It
for
costs
every
money,
county.
but the funding ran out of it for it, but we thought it was enough to take some of our money that we have from our $35 million investment and use that money for that because it had such a good outcome. And if we can make a difference in those young people's lives, we know we can make a difference in others. So again, I am going to speak to you today, hopefully from a perspective of a significant amount of knowledge, having trained at Grady in the Emory program from a long time ago. As an OBGYN, when we were doing 10,000 deliveries a year, during a time when at the crack epidemic in the state of Georgia and Atlanta, and it was a time that definitely impacted my life significantly. And even though I always knew I was going to be a reproductive endocrinologist and fertility specialist for a long time, I did a lot of obstetrics and gynecology, and so women's health has always been important to me. I won't go into all the statistics, but I think we have a hard pill to swallow when we look at our statistics, whatever way we want to look at them. And I'm going to talk a little bit about how I think we have to really capture data better so that we're comparing apples to apples and not confusing the public. One of the things that, regardless of how you look at the data, though, we know that our pregnancy-related mortality ratio is increasing compared to other countries. And we know that women of color are 3 to 4 times more likely to die from a pregnant-related cause than a Caucasian woman in this country, and that is significant. And if we look at the data, and some of you are familiar with this, is that I do think we have to look at pregnancy associated versus pregnancy related, because you are exactly right. If somebody was in a car accident and happened to be pregnant, how we count that in the database, because sometimes we're talking about small numbers, can skew per 100,000. It will take you a long time to get to that ratio. So this is important. But these pregnancy related issues, whether somebody has a hypertensive crisis that occurs that turns into preeclampsia and eclampsia and they die, or whether or not somebody has a postpartum hemorrhage, that pregnancy related, or whether they have cardiomyopathy that doesn't showcase itself until 2 months after the pregnancy, and they then end up having congestive heart failure and dying within a year. Where do we count that? Where do we count when the woman ended up developing cardiomyopathy and she doesn't die until 5 years later? Are we missing that opportunity to understand that her challenge occurred during that pregnancy? So there was something that ensued in that pregnancy. So we do have to be very clear about pregnancy associated versus pregnancy related in our calculation. And whether we want to look at the data from multiple sources, we know that Black and non-Hispanic women per 100,000 have a higher rate than white women. And so this is a concern for us, particularly when we look in Georgia and we start to look at the higher percentage. Now, we are talking about 43 deaths, okay, in 2014. That's what we're talking about, but 43 too many, okay?
Right.
I was at a national conference and we were talking about this, and someone said, well, the person literally said, we're only talking about 700 deaths. Well, when it's your mother or your aunt or your friend, that one death really does matter. And so, yes, the numbers are small, but I know that 62% of them probably can be prevented. And so then we want to work on those pregnancy-related ones, or pregnancy-associated ones, and want to understand the other things that we can do better in our country to make a difference. So when we look at these leading causes of death among pregnancy-related by race, what we see are diseases that are influenced long before a woman sometimes becomes pregnant. And so when we think about hypertension, or we think about fibroids, we know that Black women have 3 times the rate of fibroids. And so if I have a fibroid tumor or growth in my uterus and I become pregnant, and depending on where that fibroid is, it may increase my chance of having bleeding. And therefore, that increases my chance of having a postpartum hemorrhage. We also know that if you start to look at hypertension in non-pregnant women compared to black women versus white women, you see an earlier trend of the development of hypertension. So that when a black woman comes in the reproductive age and she is pregnant and her blood pressure is already starting to elevate in the first trimester, that is a different level of caution that you should take with that woman throughout, because she may have been hypertensive when she became pregnant. Her chances of being not just gestational hypertensive, but then having preeclampsia and eclampsia is increased. So when we talk about cultural competence, we're not talking about somebody necessarily being sensitive. We're talking about people being knowledgeable, okay, to understand what happens throughout the course of a person's life based on race, ethnicity, and other factors that contribute to them having an increased risk for disease. Because when you look at each of these, many of them, with the exception of amniotic fluid embolism, where somebody has not a blood clot but a fluid clot after they deliver or during a delivery, those are some of the rest of these can be tied to something else that may predispose this woman before she was even pregnant to having a higher risk. Now let's look at the data in this one. This is where I think we really have some opportunities. This is looking at per 100,000, but this is comparing us to national. This is maternal mortality in Georgia versus national, and infant mortality in Georgia versus national. But what I want to get you to is looking at this population under Medicaid, because most women in this country, at least in the state of Georgia, if we could get everybody to enroll, would have some level of care. So we're doing some things right, is that we have Medicaid access for care when you get pregnant. But if you look at this, percentage of women delivering a live birth who have had more than 80% of expected prenatal visits is only 38.2% in Georgia compared to national 61.7%. The percentage of women delivering a baby with a prenatal care visit in the first trimester, very important, because I may get an indication of some of those things that were happening with that woman before she got pregnant that may predispose her to greater risk, 67% versus 81%. And then the percentage of women delivering a live birth who had a postpartum care visit on or between 21 and 56 days after delivery. Remember, when I'm diagnosed with gestational hypertension or gestational diabetes, the fact that I'm in care for that next 90 to 120, maybe 2 years is really important if I'm thinking I'm going to see some of the sequela of diabetes or the sequela of hypertension that turns into a cardiomyopathy or some other event that influences that. And you can see in Georgia, we rank lower than in the nation, which really says to me that we need to improve our communication and our opportunity for women to understand how important, first of all, being in care is. And so we got to extend, as our previous colleague talked about, opportunities using technology such that women can have some touch point of care. And I'm really hoping that we're going to be able to do that. Not only are there social determinants, we know that there are structural determinants of health inequities that deal with education and finances and some laws and reproductive health rights. And then we have to take in consideration culture and social values. Why is it that women won't go to care or receive care when it is offered? Again, when we talk about cultural competence, it is about, are we educating our providers, not just physicians, but medicine as a team sport, of whoever has first contact, are taking into consideration what that woman's cultural norm is, her social norm, her values, and what is it that we need to extend beyond just the insurance card so that she will access to care. Again, we are all working on curriculums that help with our providers for understanding how to be more culturally competent and therefore culturally relevant for the patient.
Dr. Rice?
Yes, ma'am.
I just had a discussion, because it came from a GORC meeting talking about home deliveries. And then I had a discussion in my office with a young mother, and is anybody looking at the internet? Because what she was saying, there is so much negativism out there on the out there on the internet. Like, if you go to a doctor, they'll make you have a C-section. If you go to a doctor, they're gonna and go to the hospital, they'll make you have an induction. Are there things out there on the internet which I don't like because of this thing? Are you picking up anything like that that's causing women to not go for prenatal care?
Yes, we are. So when we talk about our Center of Excellence, one of the things you're going to see us talk about is the community engagement core. How are we having these focus groups and opportunities to talk with women to first understand where they're getting their information? And then how do we help them to validate their information? Not tell them that it's right or wrong, but help them to validate it. Because when we come in and just say to them, oh no, this is wrong, but you got to help people to go through a process. But first of all, in order to do it, you got to have trust. People got to let you into their circle. They got to let you into their circle and raise the awareness of where they're getting the information, because you are correct. And we have to meet women where they are. When women say that they want to have a home delivery, we just can't say, so when I was in training, somebody would say that to me, I would be like, oh, no. Because what I had only learned was that the best deliveries happen, the safest deliveries happen where? In the hospital, because we can control everything. Well, there are a lot of ways now that we can put resources from the hospital to the home or to other areas where women want to have deliveries so that we can meet them where they are. And we just need to become more sensitive to that, and that understanding that this is this woman's right or her family's right, and we have to respect that. And we have to be enablers for safe care, but enablers also that women believe and understand that they do have the choice. And so that's what that's about to me. So when we look at our concerns with maternity and mortality, there are 3 delay models that we're going to be studying. The delay in decision to seek care, the delay in reaching care, and the delay in receiving adequate care. And I think approximately 65% of Georgia's pregnancy-related deaths that occurred between 42 days to 1 year postpartum were preventable, which again tells me that we have to have an extension of care. We must have that extension of care. And so just for an example, and I briefly touched on this, so I won't spend a lot of time on it, but the hypertensive disorders of pregnancies, one of the things that we just had our HeLa conference on was nothing but talking about hypertensive disorders of pregnancy, because trying to understand the disparities between black and white, and really trying to understand that if you look at the parallel of black women with hypertension, and then black women who are dying from a hypertensive crisis or developing preeclampsia to eclampsia, it would parallel what we see in non-pregnant women for the increased incidence of hypertension compared to Caucasian women. So it's very important for us to understand that there are parallels that we can learn from. And so that means I have a different level of surveillance when an African-American woman comes in and she's at 22 weeks and her blood pressure is already elevated. She is already a high risk for preeclampsia, and so I'm going to see her more frequently. And when she comes in with edema and proteinuria, she's going to have preeclampsia until proven otherwise. But you have to have trained and understand and seeing that, and we have to really increase the community understanding of surveillance of that. Here's the other important thing that the center that we are running is going to do. Near misses. Near misses. This is where we learn how to intervene in a more timely manner. WHO has done a lot of work in this. And if I could just think about my time at Grady, I could count hundreds of near misses. Near misses, that is, a woman who nearly died but survived a complication that occurred during pregnancy. And the way we learned from that was that we didn't shy away from the data. We reported what happened, and we developed an intervention strategy that could be systematized throughout, such that the next time that would not be one of the near misses. Because remember, dead women cannot talk. They cannot speak. And so we have to hear from the women who survived and understand what we did not do well enough that gave them the confidence per se to come in sooner. Did we not listen to you soon enough when you were complaining of the vagueness? You didn't know what was happening with your body, but you sensed something that was different because you've had 2 babies before, and this one was different. And so how do we take that information in a qualitative manner and put it in a survey or some tool that allows us to intervene sooner? And then we take those situations and we use it in our classroom in a real life way so that our students and our residents understand how to become what we describe as more culturally sensitive and more culturally relevant. Now, Georgia is making some headway, you all. Yes, we need to do better with how we collect the data with MMRC, but we do have some perinatal qualitative collaboratives and other things that are important. So let us not believe that Georgia's not going to do what we need to do. But we need more data. And we need data on the social determinants, which I'm glad to hear my colleagues at Mercer are going to be working on that in the rural. We need to look at it in the urban, and we need to look at those social determinants based on by race and ethnicity. We need to acknowledge and address this unconscious biases that we have. Remember, they are unconscious, so people don't know they have them yet until you make them relevant to them. And we need not be ashamed because all of us have them. And then we need to educate and train to increase cultural competence, and we must engage the community. So briefly, you all know that our whole goal is not just about equality at Morehouse School of Medicine, it's about equity. It's about giving people what they need, when they need, and the amount they need to reach their optimal level of health. Some people need 2 boxes to stand on to look over the fence to see the game. So some women are going to need more than just access to the healthcare provider. They need a culturally competent provider. They may need some additional resource to get them to the doctor. They may need telehealth. They're going to need different things to stand on the box. We believe that diversifying the healthcare workforce is important, and it's because we know what happens with cultural competence, and it's not a one-size-fits-all. We have to make sure that we align. We have to know our counties where we have need. And I think when we look at what Mercer's doing and what we're doing, if you put the 2 of us together, we are both intentionally focused on making sure that our state of Georgia, that no county is going to be left behind. And we have people throughout the counties who are making a difference. And many of those people, what I love is that many of those people come from those counties. That's how you get people to go back to Tenno and Sandersville, Georgia, and other places. You got to recruit from those places, and each of us know that. Now, here's another thing that we've done, though, that I think is really important. Our blueprint for action is where we actually started to ask some questions based on the highest need of health outcomes, health factors, but then we looked at what were we seeing with infant and maternal mortality and looking at drug overdose death, and we're about to add the marijuana component of that because we know we are seeing an increased number of women who are pregnant using marijuana, which is an interesting phenomenon, not something that we sort of expected. But I think with everything that's happening with marijuana, people are getting much more comfortable. And as people get more comfortable, they get a little bit more lax with some of these things. And I think that we have to be much more intentional in talking about what are the challenges of marijuana use in pregnancy. And so we're going to add that to our map here, but you can see there are some counties, particularly down in Randolph, Early, Clay counties, where you see the greatest need for health, looking at their health outcomes. You see those red circles where the half moon, where you see the counties that are accounting for 1/4 of the maternal deaths. We have been engaged in a community engagement, going down and doing focus groups in those counties with every agency or grassroots organization that is doing anything in health, and saying, how can we be more supportive? Not how can we tell you what to do, but how can we leverage what you are already doing in this space to make a difference? And here's one of the things that's very interesting. If you look at this slide here, those counties with those half moons of that are red, a quarter moon, red counties, what you see is those are the same counties that have the shortages of whether or not they have a pediatrician, an obstetrician, or a doctor at all. So access still continues to matter. And you are right, whether or not we should try to have a provider in every county. No. You can't, you're not going to get an obstetrician in every county, but we got to get access for every county. And so what means are we going to use to make the difference here? And so just finally, on our Center of Excellence on Maternal Mortality, let me thank the legislators for believing in us and helping to get that money back into the budget. We appreciate that. We appreciate that. It's going to have 3 cores: research core, training core, community engagement. We're going to talk about scientific research. We do need more research, because you all, even when we control for socioeconomic status, that means African American women compared to Caucasian women, and they both make $150,000, and they both have had more than 80% of their prenatal visits. We still see a higher rate of death among Black women. So, is it those diseases that disproportionately impact them prior to pregnancy? Is there something inherent in our system that's creating a structural barrier where women are not being listened to? It is probably a combination, but we have to dig deeper into understanding that. And we believe that we have the trust of the community and can go out and ask some difficult questions and come back with some answers that hopefully can help us with an intervention that we can systematize, not just here in Georgia, but nationally. We need a training core. We need a training core to talk about when we develop strategies, whether it's at Morehouse or Mercer or whatever institution that works, how do we systematize those strategies and get them implemented throughout the state so that we can see a real decrease in the maternal death? And then we have to have an integrated approach for sustainability. You will not get that unless you have the community engaged. The community has to be a part of that. And so you have this in here which talks about specifically what we're going to do in the research core. A large part of this is going to be looking at the near misses. And so there will be some different things that we will ask MMRC and some others to help us with in reporting. So right now we do it in our morbidity and mortality rounds at different hospitals, but we have to report these near misses so that we know everybody who was diagnosed with preeclampsia and what led to that diagnosis. And then how do we get this patient over here not to become preeclamptic to eclamptic versus one who became eclamptic versus one who passed. And so in order to know that, you have to have a much richer database, and we're going to have that. And so finally, we are engaged with the American College of Obstetricians, Gynecologists, the American College of Nurse Midwives, and the National Medical Association in a national conversation about extending care beyond the 90 days, but for a year up to 2 years. We have a meeting November the 5th with the National Medical Association and Humana, Centene, and United Health Group, and we're going to be talking about them about a longitudinal national study where we will enroll women who are diagnosed with gestational hypertension, gestational diabetes, and we will keep them in care for no less than 12 months after their delivery. and we would compare them with a 2-to-1 match based on age and when they were diagnosed nationally to understand if the interventions that we are talking about implementing beyond that 90 days will make a difference. So the solutions: more data, specifically around the near misses, access to both culturally competent providers and insurance beyond 6 weeks, comprehensive training, and comprehensive engagement. And thank you so much.
Well, Dr. Rice, thank you. If somebody from the governor's office was not watching this live, I certainly hope they will pull it up, and I think they will see why I'm a big supporter of you getting your money and why they let you run things at Morehouse. Just one place before that I feel like we're lacking, and I'm curious if you think this would be helpful. It seems like we have a public health office in every single county, and that if you found community workers from people's communities, and they were able not to drive to another county, but to that county's public health office for telemedicine with the mothership or place that you're satelliting with,
Right.
that would sort of give us, and the same thing that Mercer's talking about, that would give us that continuity of care, that tiered approach.
Right.
Do you feel like, I'm not trying to be hard on our public health system, but it is run by not the state, but local boards, and sometimes there's a disconnect. Do you feel like that would be a big step?
I think that would be very helpful, and if we combine that with community health workers.
Right.
Lay community health workers. So we have a curriculum that we've been running now for 3 years for high school community health workers. We start training students in the 10th grade. We've had our third cohort of students, 30 students per year, and they become the chief medical officer for someone in their family. They come to us for a 6-week program in the summer. We connect them to the primary care doctor of their grandmother, whoever it's going to be. And then they come to us once a month, and they're bringing data about that person's care and engaged with, just like how do people not smoke in your household? Because your children tell you shouldn't smoke. But they are on their parents and grandparents being engaged. We can do this at a high school, college, and layperson level, this community health workers program, such that every pregnant woman in the state of Georgia ought to have a community health worker network of people who are helping her through the pregnancy. We value pregnancy in Georgia. We value that. So let's not waste our opportunities. Let's leverage the opportunities to use it as a time to bring the community together so that we can have these great outcomes. And I believe the public health sector is a great place to have the centralization, because everybody really could now do it on the cell phone. You could do the visit on your cell phone, but we may want to have more structure to bring people together so that we have more of a community impact. So I would be very much open to supporting that and partnering with our colleagues at Mercer to talk about how we leverage both of our resources to do this better.
Well, I think that would just be a great. I went to school back in the day, I don't say how long ago, when public health was a big provider of health care, actual patient care.
Yes.
And I had enough of it in the mountains that I decided I didn't want to do public health.
Right.
But other than that, but what I wonder is if it's not also a pipeline for students for our nursing programs and other programs. Has it gone on long enough? Have you seen any of these?
Yes, so we
workers?
probably have about 60% of those students who are now majoring in something health related. So it becomes a pipeline program for us. It's a significant. We also have an HCOP grant for students in high school that we're using very much similar the curriculum. And again, we're seeing about 80% of those kids who are choosing a health related field to go into when they go into college. So
I think that's great. It lets students see what's involved in the healthcare field and see what they can do and how they can give.
Yeah.
Representative Hughley.
Thank you, Madam Chair, and thank you, Dr. Rice, for what you all are doing at Mercer. I just want to...
At Morehouse, why y'all want to give me Mercer?
She got me saying Mercer.
I did it. Okay, one of y'all are going to have to change your name.
Morehouse
Doesn't start with
School
M.
of Medicine. Well, you know, Mercer's coming to Columbus, so I guess you got that on the brain. Of course, Morehouse is in Columbus too. So
We are. Thank you.
I'm about to forget what I was going to say, but anyway, I want to thank you for your presentation, and I want to thank you for the work that you all are doing in cultural competence.
Yes.
Because I think that it's very important for this particular discussion. And I also want to thank you, Madam Chair, for encouraging the governor on this $500,000 that we need for the program that we had outlined in our budget. So thank you for that, and hopefully they are watching.
I hope so too, and you don't worry, I'm on it on a regular manner. The other thing I'm on and have been begging for a year, which people from the presenter from Mercer, is the expansion of our coverage up to a year.
Yes. Yeah.
And, you know, sometimes you have to compromise, and I don't want to, but I'd compromise at 6 months, but I'm been begging for a year of coverage postpartum.
Particularly if we can take that information that we're gathering, and then, I mean, we can do a real-time study to compare it to women who received care for 6 months and then those who did not. And we will easily be able to show, better control of hypertension and diabetes with women who were diagnosed gestationally. We will easily be able to show that.
I mean, I would even take some pilot projects if that's all I can get. But,
Yeah,
you know,
right,
try to go
exactly.
for the whole banana instead of parts of it first.
Right. Thank you very much.
Thank you very much
right,
for your
thank you.
presentation. Okay, and next up we have from the Medical College of Georgia at Augusta University, Dr. Ray, a member of our committee. Dr. Ray.
I fear y'all will get tired of hearing from me, so I will try to keep my comments very pointed, but I will take an opportunity to highlight some of the things that we've done. So thank you, Madam Chair, for the opportunity to speak today and to serve on this committee. I'll talk about our maternal health initiatives. I am an obstetrician gynecologist at the Medical College of Georgia in Augusta. I'll just focus on a few areas for us. I'll give some brief background, and I will talk about how we tend to believe we need to stay in our wheelhouse.
Okay.
So I'm going to stay in my wheelhouse. Number one, I know we do education, so I'll talk about our Georgia Center for Obstetrics Reentry program, for which is funded by the state and the only one of its kind. And it can be done in any state, and we are absolutely on the forefront of something that everybody would say that it's a good cause. I'll talk a little bit about some of the research and clinical care partnerships that we have brewing in Augusta for cardiovascular disease and obesity. And I'll talk about some rural health partnerships, and Dr. Miller will talk about educational initiatives for rural health. We've talked a lot about, or at least seen, slides on the social determinants of health, so I just took an opportunity to circle some areas on these slides that would tell you where we are focusing for us, and that's in clinical care, advocacy, research, and education. And I'm very proud of the fact that my own department in obstetrics and gynecology ranks number 6 in the nation in NIH funding, which is really outstanding. We also have a Center for Rural Health, and we are a regional perinatal center at the Medical College of Georgia at Augusta Health. I really just wanted to take an opportunity to not beat a dead horse, but just make a comment on something that was sort of life-changing for me as far as my career goes. As a surgeon, I like to see a problem and fix a problem and move on. And I get asked all the time, because of my experience and the amount of time that I spend, an extraordinary amount of time, if you ask my wife and kids, thinking and talking about health disparities and the way to narrow the gap so that we don't continue to hear that African American women die at 3 or 4 times higher than Caucasian women when you account for everything. And I think it's the way that any place fixes the maternal mortality crisis, if you will, in our country is to, one, have data that is accurate across the board for everybody and stop comparing us to places that don't count. Also, figure out a way to narrow the gap. And I've seen it once where data was presented to me at a meeting where a state nearby showed that it was nearly 1-to-1 ratio for African American to white females dying as it related to maternal mortality. And the next year, the disparity was there again. And so whatever was there was an artifact, while I thought that we might have an answer. But when I get asked the question, all I can say is it's so complicated and there is no one answer. But I am going to show a slide that changed how I feel about disparities. And this came from arguably the person who, to me, is the best at data, especially related to maternal mortality. So I stole this slide from Dr. Callahan, who was formerly at the CDC, from a presentation that he's done. And this slide is an old slide, but it was from the meeting that he just did at the Georgia OB/GYN siting. And this shows pregnancy states. So every dot on the map, on the graph, is a state. And when you look at states that have a higher population of African American women, they have a higher rate of maternal mortality. And that is just simply in the numbers. If nationally there is a health disparity that says African American women nationally will die 3 to 4 times more likely than white women, when you have a higher population of African American women in your state, you will always have a higher maternal mortality rate until the disparity is fixed. So I highlighted it here because the maternal mortality rate in the Southeast is higher than it is in places like California, where we're also compared all the time. So if California's got a 7 per 100,000 maternal mortality ratio, they also have they rank 31st in population of African American women. And in Georgia, we rank 4th. So again, I think the answer is always going to lie in figuring out a way to narrow the gap. And so while it could be related to access to care, rural health, genetics, there's a lot of things that go into this. The answer is it's all of the above. So I'm going to highlight some things that we've done at the Medical College of Georgia. First, I'll go into my own program, which was the Georgia Center for Obstetrics Reentry, and we tried to do something that had never been done. I kept getting the question as to how do people who've been out of obstetrics for more than 2 years, how do you get back into delivering babies? And all I knew is that we have a workforce shortage. We have a higher demand than ever, and that's going to, even if we have more individuals in residency and med school, the demand will exceed the output. And so the workforce shortage is going to be there, and it's not going to go away. So while this would have a minimal impact, what I wanted to do was prove concept so that our state would be on the forefront for that, and also we would be doing something that would at least increase the number of obstetricians in the state by some small amount. And so starting in 2004 through 2016, this was a lot of blood, sweat, and tears, and lots of folks, even in this room, who went to bat for us and me, and we had our first graduate from the program in 2016. The program, there were lots of things that could have made this fail, but at the end of the day, the malpractice issue was the biggest one. And so the program had to be built as a structured volunteer program. These individuals give up their time, they give up their life, really, maybe even from outside. The current person is from Oregon. And so she's going to be an obstetrician in Georgia, but she's moving to Georgia from Oregon because she wants to be an obstetrician that bad. So the aim of the program was to alleviate some workforce burden, but it wasn't going to be at the expense of quality. So all of these applicants had to be board certified OB/GYNs or in family practice with a core of obstetrics training. They had to have an unrestricted Georgia license, and they had to have voluntarily left practice. They couldn't be someone who could not be board certified and needed to get recertified for some reason. The program was built much in the way, because I think we're pretty good at training residents, so I built it like I was training residents. That way I could have an assessment tool, and so you can see it's a flexible curriculum, and we supervise them and evaluate them just as we would residents. And they are credentialed through our hospital. They are covered for medical liability through the Department of Administrative Services for the state of Georgia. The funding is provided by the state, except for their living expenses. They're supervised by board-certified academic OB/GYNs who are compensated by the state, and they work in all clinical settings. This is since 2016, we could have up to 4 graduates a year. One of the gaps was I had to have a 9-month hiatus to figure out how to get the malpractice insurance through the state. The red tape through that was significant. But since then, we have increased the number of obstetricians through this program by 7. We had one person who moved here from Arizona who left the program just simply because he thought he could also be given an opportunity to retrain in gynecology, which is not what the state agreed to, nor myself. And we have been able to put these individuals back into practice as obstetrician gynecologists, only one of which is not a delivering physician. This gentleman was a pharmacist. He'd been out for nearly 20 years, just wanted to be a doctor again and do prenatal care. So he's become an outreach coordinator actually for the Medical College of Georgia, where we're looking at putting him into rural areas around us because we know we have a maternity care desert. And we have a current person. 2 of these individuals who will finish the program were not from the state of Georgia, and they are required to practice in the state of Georgia when they finish. So they will be moving permanently to Georgia.
Are they older physicians? I mean,
Not in all cases. There's, for example, I have someone who was a family practice doctor who had trained in obstetrics, who works at an academic center in South Georgia. When she had been out for two years and like 2 months from doing obstetrics in a private practice setting, and she was going back into academics where she was going to be training family docs to do obstetrics. Her hospital would not credential her. So she came to Augusta. We got her the delivery volume that they would need to credential her, and now she's teaching family practice docs to do obstetrics in an academic center.
okay, how do they make a living if our coverage for malpractice is only if they do it for nothing?
That's only for the up to 90 days they're in the program. They
Oh.
get their own malpractice afterwards.
Oh, okay.
The
After
state's
that-
not covering them except for when they're in my program.
Okay, all right, got it. Sorry.
So no, that's fine. Thank you. So we have an evaluation process that shows that the participants it's very positive for them. It is mixed from my residents. It does challenge the residency sometimes as far as having an additional learner in that role that's not well defined either. They're not faculty and they're not residents. So they have a board certified OBGYN who they might be, asking to do things just like they would one of their colleagues. But overall, one of the bigger issues is just job opportunities. So we always seek for opportunities to coordinate so that when they finish the program, they don't have a lag in getting a job. If you're moving to Georgia from Oregon and nobody wants to give you a job before you finish the program, what I don't need them is sitting out, having them gain more rust after they come and do their program with us. So. And really the most impactful piece of this is that it costs could be up to $400,000 to train a resident over the course of 4 years. So that's $400,000 each. The state investment is about $50,000 per physician that we put back into practice. So it's really, for return on investment, we've put 7 obstetricians back into practice in Georgia for a fraction of what it would cost if they were going through residency, and even less money than it would be if it was just one resident going in to do obstetrics. I'll just make a couple of comments because I want to highlight some of the things about the health disparity. We know that cardiovascular disease is a major contributor to maternal morbidity and mortality, and it's a clear contributor to population disparity for African American individuals, men and women. And there are a lot of reasons why, and this is just information from the American Heart Association that I will not read. What I will say is that we've known since the 90s that there is, when I'm asked the question, why, I can tell you, yes, implicit bias and discrimination in the healthcare process makes a difference. Yes, it contributes. Access to care makes a difference, yes, but there is something very different, and I appreciate the comments from the folks who spoke earlier, because there is definitely, when you account for every other aspect of social determinants of health, even the most money, the most education, an African American woman still has more risk during childbirth than their age-matched peers that are Caucasian. There is a research project ongoing at Augusta University that looks at sex hormones during pregnancy, and as it relates to both race, age, and cardiovascular disease. And so this is just a mere example of what I think really needs to happen, which is there should be more efforts in academic health centers around our state and the nation to really identify that piece as to why. When you account for everything else, why is a single individual more likely to have cardiovascular disease, whether it's hypertension or some downstream effect for or for stroke? And we know that African Americans are at higher risk. We know that obesity is a major contributor as well, and there is a clear contributor. This is also a clear contributor to population disparity. So I just simply put a map here that shows that, yes, we are in an epidemic, and I wanted to highlight a partnership that we're working on in Georgia, at the Medical College of Georgia. And we have a metabolic and bariatric surgery program for which we are trying to identify individuals that are candidates for participation in this program. It is covered by Georgia Medicaid, and as you've already indicated, that as a supporter, I'm certainly a supporter of having postpartum care extended for as long as possible. I would take anything, but I would also ask for the world. I think that the return on investment here is that if you have to treat lifelong diabetes, hypertension, and the complications that go into that, bariatrics program, even bariatric surgery, gives you a huge savings. And so there is an opportunity for us to identify these patients during pregnancy. We're going to give them a online seminar, start the pre-authorization period, so that when they're outside of the pregnancy period, if they still have the coverage that would allow so, it's a safer operation for individuals that qualify than having their gallbladder removed.
We were laughing at Dr. Newton and I because Katie Dempsey, when you said that, has had a bill several years, and for a while we were running a program about the obesity surgery, and then it went away. Or did they extend that one and do medicines, or did they extend the medicines? And
I don't think we approved the medicine.
We didn't.
I don't think we approved
So
the
we
medication
maybe,
one.
okay, we're expanding it another time. So we're trying to get it, and that's in the
State health benefits.
State Health Benefit Plan. So we were smiling because Katie Dempsey is on that, and she's about that big. And so,
I work closely with our bariatric surgeon who spends a lot of time in Atlanta lobbying for that benefit for the state employees. I won't beat this dead horse, but I will highlight the fact that when you look at where I practice in a high acuity academic medical center where everybody I take care of seems to be extremely sick, I don't think it's an accident that there's dark green surrounding my area. And so that map, I sit and look at it all the time, and it just makes me ill. But what we're trying to do is something that, as you were giving me a perfect segue, Madam Chair, because we are working to actually do all of the above what you mentioned. One, we're putting individuals into the counties that surround us, and we're developing partnerships in those counties already. So this is an example of one of the hub and spoke model for obstetric care for us. We work with Dr. Carter and Christian in Waynesboro. We've partnered with them. They get something from us. We get a huge amount from them. Roughly 150 deliveries a year come to us. They are good prenatal care physicians. They're family docs, entrenched in the community. They've been there for a long time. They don't have a way to take care of patients on an inpatient model, so they deliver in Augusta. We cover them for some things like their malpractice. The university covers them because they're partners with us with a program letter of agreement. And the individuals down there can get all their care. They share the records. They know to come to Augusta. They have their babies closest place, and we can identify those individuals that are at risk for any comorbidity because they've got good care in their community. The other model is that if this is my dream come true moment to talk about partnering with the Department of Public Health, because as I have already started these conversations with Dr. Toomey, I think that the Department of Public Health being in every county, having the capability of doing telehealth already. We've worked with the Department of Public Health to participate in grant writing already, unfortunately not funded federally, but take the opportunity to use the resources that are in the communities, use our resources as clinical FTEs, right? So we have someone, whether it's at some level, whether it's a certified nurse midwife, a physician who does obstetrics, or it's a maternal fetal medicine specialist, and use the telehealth model. We also have a grant federally for an app development where we're taking individuals, and you mentioned you can do these, or I think you mentioned that you can do this on the phone. And the truth is that we want to have someone, if there's capability to use an app, the app-based product that we have running through the a HRSA grant right now is that they can list a couple of questions, including, we give them some things like a blood pressure cuff, but they can give us their blood pressure daily. We can give them, they can dip their urine for protein. We can even do a sort of mental assessment as far as their depression scale that day. That information gets sent back daily to a secure file in our system, and then we can look at it. It'll be flagged if they score high enough on any of these areas. So we're trying to figure out any way to take the model away from them having to come to Augusta because they don't have transportation, they don't have means, and this kind of thing. So I'll leave it there for questions, and then for Dr. Miller.
Any questions before we move on? Representative Hughley.
Thank you, Madam Chair, and thank you for your presentation. My question goes to this app that you're talking about, which is interesting. With the rural connectivity, would that be a problem with having an app of that nature? Or how do you get around that?
We often discuss that. And yes, it has the potential to be a significant issue. It's not so much of an issue when we look at where we would pilot it. Oddly enough, the pilot program that's being done now is not done in the east central region of Georgia, where the research is being conducted ultimately, but it was chosen to be in an area actually where there was limitations for connectivity and things like this. So yes, the answer is that we could have the potential for having an issue if this was to be used something statewide in all nooks and crannies, but the reality is that it's becoming less of an issue, at least certainly for our region where I think it should be focused.
So one tool in the toolbox, not the only tool. Okay.
We focus on as many tools as possible because it's a complicated problem.
One other question, and that is on medical liability for OBs. I remember at one point that was a big deal, a big number. Is it still a big number for them?
It's certainly a big number. It certainly depends on where you are nationally. Georgia is certainly not the worst state as far as medical liability goes, but even within Georgia, there are places where it's very bad. Metro Atlanta is very different than it is in other areas, simply because it's Metro Atlanta, I think. I don't have a good answer for it, but I know that there are many states where there is a high attrition rate for obstetricians, especially in the Northeast. When someone gets sued, it's obviously difficult. It takes a toll in practice. It's a reason why that contributes to the workforce shortage. States like Texas that have very clear tort reform legislation, folks flock to Texas to do obstetrics and gynecology because it's a very favorable place to practice. And there's a huge population there, and they have a big need. So it's also complicated, but to answer your question, yes, it's still a problem. Medical malpractice insurance for obstetricians is still very expensive, and when you pay that bill, you got to deliver a lot of babies just to pay that bill.
I mean, would a range be, I've heard a range of about 50 to about 150. Is that probably a range that you have heard, or?
I can tell you that I am not capable of answering that question with any, because I work I'm a state employee for Georgia, and I'm covered by the state of Georgia. So I personally don't get that bill.
Okay, I've heard that's a range, and that's been several years ago. And if on the lower end, it would be somebody right out that hadn't been sued or.
I've seen a bill of about $35,000 for someone just doing prenatal care and not ever setting foot in the labor and delivery unit. So
$35,000 for just doing prenatal care and never delivering a baby.
For my reentry program, when the first participant who came to my program that was not covered by the state DOAS at that time, she wrote a check for $30,000 to come spend 90 days at MCG. So it cost her, because she was in a place delivering where everyone else is covered by the state. She paid $30,000, $10,000 a month to come and be a 100% proctored doctor where she didn't get paid a dime. So that, one, it was important to her, and two, that was an expensive bill. And nobody else yet could do that. That was why it was so important to have the state cover for that.
Okay. Dr. Newton.
Hey, I appreciate that presentation, and I'm impressed with the app and the hub and spoke model. I think it kind of relates back to what I was talking about, our small counties, and how hub and spoke is probably going to be it. Is there ever a formula at which you move the high-risk patient? They may not qualify to be in the hospital, but do you ever move them near? Because I know, especially in South Georgia, the distance is maybe even greater than Jenkins County coming up to Augusta, 60 minutes. I don't know. I'm sure some it's an hour and a half on backcountry roads to get to wherever the hub would be.
There's definitely a model for that. We do it in cancer care. Lydia House in Augusta
True.
is for cancer patients who come to get their care at the Georgia Cancer
That's a
Center.
good example.
So that's the best model. We also do it with the Ronald McDonald House, and we have a partnership with individuals in Albany. So if you have a child with a gastroschisis and they're going to have to get pediatric surgery, they relocate to Augusta closer to the time when it would be important, and then while the child's in the neonatal ICU, the family still stays in the Ronald McDonald House. So there is a model for that. I don't think that because the hub and spoke model, as we have developed as a state and a healthcare, delivery system, because that question has never really been raised so much, and we're just now working on it in the early phases. That's something we could probably, decide if that's something that needed to be done. Certainly, it's too expensive to keep them in the hospital. They don't need to be there because today you just can't do it.
Thank you.
Okay.
Thank you.
Oh, go ahead.
Thank you, Madam Chair. I did want to talk a little bit about the hub and spoke from South Georgia, Thomasville, and we already had our hospital doing a similar process. And our OBs ran into trouble because they were having so many Medicaid. Close to 80% of our births were Medicaid. And we ended up working with our FQHC, who now houses our midwives, and they're overseen by our OBs, and it has worked very well. And that might be, again, another model that we can look at, and they extend into the 4 surrounding counties. So it is a good model. Anything we can do to help you enhance that, please share that with us.
Yeah,
Thank you.
That's actually a great model. Thank you for bringing it up. I think that's, for me and for anything that we do as a department, it's not about reinventing the wheel. Partnering, I'm surprised that other places in Georgia don't partner as much with public health. I do know some limitations there, but our residents go into that, into the public health. They participate in pregnancy centering, and I think some of that actually was because of what happened in other areas of Georgia, including in your area. So thank you.
Okay, we're ready for Dr. Miller, and you're the Vice Dean and Professor at the Medical College?
Yes, I am.
Welcome, sir.
Thank you, Madam Chair, and members of the committee. It's nice to be here. I've certainly enjoyed hearing the comments of true experts in this field, and as a cardiologist, I won't pretend to be an expert in the field, but I have been the dean of 3 medical schools in the U.S. and Canada and know a little bit about medical education, so I'm going to talk to you a bit about that. The problem is illustrated by statistics often. I'll give you statistics that are recent and valid from the OECD. The worldwide maternal mortality rate per 100,000 is 261. In sub-Saharan Africa, it's over 500. In Canada, where I'm from, you can probably tell I talk funny compared to you folks. It's 7.8. Pardon me. In the United Kingdom, it's 9, and in this country, it is 14 on the average. And you've heard some of the other numbers from colleagues that point out that it's much higher in different areas. That tells us something, I think. It tells us about, probably the most important thing it tells us about is access to primary care. Because in countries where we have socialized medicine, Canada, the UK being 2 examples, whatever you may say about the problems with those systems, those people have access to primary care. And those low maternal mortality rates reflect the fact that any Canadian and any member of the United Kingdom, any citizen, can go to a primary care physician without constraint. In fact, they cannot see a specialist in any discipline without having first seen a primary care physician. So the solution to this problem is societal in part, but it's also related to access to primary care physicians. So as a medical school, the biggest medical school in Georgia, the 9th biggest medical school by enrollment in this country, and about to be the 4th biggest medical school in the country within the next 5 years, we've decided that the access to primary care approach will be one thing that we will contribute to this important problem and try to improve upon. So I'll go through that thought with you, and then we can chat about other things perhaps. So we're a big medical school. It's a colorful diagram. Focus on the orange box, if you will. We have a lot of volunteer faculty, 2,500 volunteer faculty in practice, not employed by the Medical College of Georgia, but in practice across Georgia. We have 791 faculty, including Dr. Ray and other excellent faculty employed in the Medical College of Georgia. We have a large number of medical students, a large number of residents, and 51 programs. So we are a big engine for developing doctors for the state and for the country. We've also, for the last 10 years, been developing a statewide campus model for medical education, and we like to say that Georgia is our campus, and of course we share many of those venues with other colleagues around the state, other medical schools, but we have explicitly developed a clinical education model that involves these campuses in a hub and spoke approach to medical education. So the yellow dots represent the hub, but the spokes reach out 60 to 70 miles around each of those hubs where our students go every day to train in different sites around Georgia. And 40% of our students every year are working at those off-site campuses. Our students come from Georgia primarily. They come from rural communities all across the state. I don't want you to focus on this too much other than to say that in almost every county in this state, we have students coming to us every year to do medical education at the Medical College of Georgia. And often those areas are also served by federally qualified health centers. So we begin to look at the federally qualified health centers as training sites and as sites to partner with to deliver health care that's necessary for folks who live in these different communities. We are a producer of a large number of graduates who go into primary care. At MCG, we had 245 graduates in the last class entering GME. The majority, of course, entering into primary care was 68%, and of those, 33% were staying in residencies in Georgia. We are still a net exporter, however, of medical students after training to other states around the country. So we need something to deal with that, and we decided to be explicit about that. Just another couple of these county-based maps, which are quite impactful, I suppose. 89 of 159 counties are medically underserved. We are 40th in the United States in primary care physicians per capita. So we have a shortage of primary care doctors in this state that puts us in the bottom 20th percentile of all the states in the union. There's been a lot of research into primary care. It was invented as a concept in the 1920s, but basically it's providing folks with access to a physician for primary care needs, which includes simple illnesses, prevention, and other things of that sort. And it's grown and is now 100 years old, which I thought was worth noticing.
Could I ask a question?
Yes, you may, sure.
Are your primary physicians trained to deliver babies and to do pediatrics?
Our primary care physicians that are in pediatrics, general pediatrics, are trained obviously to take care of kids, and our obstetrics and gynecology residents are trained to take care of women who are delivering babies. Our students are exposed to all that.
Okay, but our family medicine, right, does both.
And family medicine, our family medicine rotations for our students all across the state expose them to family medicine physicians that do and don't deliver children.
But you're calling primary care the division. Primary care.
I'm calling
you're
primary
saying-
care all of those things: general pediatrics, internal medicine, family medicine, and in this state, primary care also includes general surgery and OBGYN. Yeah,
Okay.
yeah, that's correct. That's not what that paper referred to, the Milbank Quarterly.
Okay.
It was more talking about family medicine and primary care physicians who are generalists, basically. We do know that when there are more primary care physicians, the health system is better served, and the statistics generally are good. And this is just one of many papers we could cite from JAMA that points out to those countries that have health systems that emphasize primary care tend to have better health outcomes. And that also applies to pediatrics as well, just as this paper says. So what we're doing and what we're in the process of doing is two things. We're in the process of growing our medical class, which you can see on the bar graph, from its current 920 students in all 4 years of medical school up to 1,200 students by FY24. That has to be done in concert with our accrediting body, but the growth is already beginning with addition of 10 students per year in our Athens campus beginning in the coming year. We've also created a new primary care track in our program called the MCG 3+ Primary Care Pathway to increase the number of graduates that are pursuing residency programs in primary care, those 5 areas that we talked about a moment ago. And in the maturity of this program, once again by FY24, that will generate 50 more primary care physicians from our class practicing in Georgia than it does right now. So we will add 50 more students to Georgia's primary care population of practitioners every year when the program is at full maturity. The pathway number 1, which we're talking about here today in this new curriculum, involves students doing 3 years of medical school and then going into a primary care residency program in one of those 5 areas: internal medicine, family medicine, general pediatrics, general surgery, or OBGYN. So that's the vehicle by which we will increase the number of students pursuing primary care careers. As you know, this program will address the shortage of physicians in various parts of Georgia, and you probably know these statistics as well as anybody would, but family medicine not present in 11 of Georgia counties, internal medicine not present in 37, pediatrics not present in 63, surgery not present in 78, and obstetrics gynecology not present in 75. Mental health, the data are unavailable. That just reflects the fact that in many of Georgia's counties, there are no providers in these areas of what we would typically call primary care or could be called primary care. Obviously, you are aware that much of Georgia is rural, and 120 of the 159 Georgia counties are rural. So when we think of where to put our campuses, we have not put any campuses in Atlanta because it's not rural. And we believe that that increases the likelihood that our students who train at these campuses around the more rural parts of the state will actually be more likely to return to the areas they came from originally and practice in the future with this new program. The rural physician workforce is aging, as this data shows, from 2000 to 2017. You can see how the population of rural practice physicians are growing older, basically. Many more of them are above 50 years of age, and they're declining in their numbers, being forecast to decline in the future. So rural physicians are going to become harder to come by, and they're going to be, generally speaking, if these trends continue, older when they are practicing. This is just another paper which I threw in here, which you can read at your leisure, but basically it points out that barriers to health care are access in rural counties. You know that. Not every rural county and not every rural community can have a physician, but as you've discussed, the hub and spoke model is quite attractive, and for the price of a patient being transported 60 miles or 70 miles into a center to a primary care physician, you could do very good primary care prevention and prevent a lot of the complications that are not being picked up and not being treated in advance. So what we do is connect to the rural communities and to the communities around our campuses. We connect to those campuses with people and with technologies and with all sorts of enthusiasm on the part of our faculty and students who are shown in these pictures. It takes a strong connection to the community, and our best connectors to the community at Medical College of Georgia are our students and our faculty. So if we have 1,200 students enrolled every year and 2,500 community-based physicians teaching them, that's an enormous workforce that could be mobilized to do any number of things. We hope they practice primary care in communities that need primary care physicians. We don't propose directly to solve the problem, but we feel that indirectly we can significantly address this issue by putting more of our graduates and our faculty into the communities to work closely on health problems of many types. We also reach out with technologies. This is our new ultrasound network where we train residents and students at the various campuses to acquire ultrasound in the field and basically transmit those images back to be read by experts in the Augusta MCG campus. This is important training for our students and residents. It gives them point of care capabilities to deliver ultrasound services to people that otherwise could not get to an ultrasound laboratory. And we also use telehealth and other patient mentoring and community-based programs such as the ECHO program that comes out of the University of New Mexico. The partnership opportunities are enormous we would like to propose that our part of this be interactions with federally qualified health centers. So we are trying to create teaching health centers out of federally qualified health centers. Georgia has no teaching health centers as part of that GME program that's run by HRSA. We would like to create the first one, and we're working with our colleagues in the Albany area to begin to try to develop the first Georgia-based teaching health center. And obviously our students are working and will increasingly work with federally qualified health centers, we hope, in the coming years. So those are my comments. The only thing I would add to that is that in Canada, the Indigenous peoples of Canada, the First Nations, also have 3 times higher maternal mortality than other Canadians. It's a social problem. It's a societal issue. And all countries that have that kind of discrepancy need to, first of all, recognize the basis for it and then address it. It is clear that access to those services are being metered or throttled back for a variety of reasons, but it's mostly money, distance, and access to care, right? So you cannot necessarily change the amount of money that's going into a community, although we would like to see that happen, economic development. You cannot change distances because they're real, but you can change access. Being close to a primary care physician makes 100% of the difference. In Canada, if you have to have a heart or lung transplant and you live in Newfoundland, Nova Scotia, New Brunswick, or Prince Edward Island, you have to move to Toronto for 6 months in advance. That's the crappy part of the Canadian system. The good part of the Canadian system is primary care for every single person. So when this state has primary care available to every single woman, that number will go down to 9 out of 100,000. It's as simple as that. So the sooner we take that upon ourselves as a mission and try to approach it any number of different ways that we can together, the better off all those folks will be. So those are my comments. Thanks.
Thank you. So what you're saying is that since many of the predisposing diseases or issues that lead to maternal mortality or near misses
Yes.
are those like hypertension and so forth that begin early.
Yes.
And if there was a primary physician taking care of them early,
Unequivocally, yes.
then that would,
That is the only solution to that number as a statistic.
okay.
Now, there are many reasons that women should also have care by specialists and, have
Sure.
other higher end care when they develop their conditions. But that is the thing that moves that number down to 7 or 8 out of 100,000.
Would
So,
be early.
Yeah.
And I appreciate the fact that you mentioned our federally qualified health programs. I'm a big pusher of those. We have 229 locations across our state now. People don't know about them. They treat people for nothing or on a very low sliding scale,
Yes.
or they'll take Medicaid, and they are truly a safety net, and they just people don't know about them,
Right,
and they're
right.
all over. So thank you very much. And a
absolutely.
teaching one sounds like a great idea. Thank
Yes,
you.
Thank you.
There are no other questions.
Good.
Okay.
Great, thank you.
Dr. Jameson. And Dr. Jameson, from Emory, you are last but not least. We're going to run a little bit over time, but you have your time to present. I hold a special place in my heart for Emory. My husband went to undergrad medical school and got his MPH from Emory. He was an Emeroid through and through. So we're glad to have you. Thank you very much for coming and waiting. Thank
Well, I'm
you.
delighted to be here. Thanks so much, Madam Chair, and for the all the committee members. I do not have PowerPoint slides. I'm just going to talk through a few of the things that we've been thinking about at Emory. I've been practicing obstetrics at Grady for 22 years, and in fact, I walked over from labor and delivery today, got somebody to cover me so that I could be here. Obstetrics in Atlanta is near and dear to my heart. 3 months ago, I was appointed to be the chair of the Emory's Department of Gynecology and Obstetrics, so I'm here in sort of a dual capacity as a practicing obstetrician in Metro Atlanta, as well as representing the Emory Department of Gynecology and Obstetrics. So we've heard a lot of different numbers this afternoon, and I'm not going to get into the numbers, but basically I think the pattern is clear. maternal mortality ratio in Georgia is among the worst in the nation, and there are large racial disparities. And I think that's the story. I think the other story is it's not just numbers and statistics. It's actually people behind the statistics that are really meaningful. There was a CDC scientist here in Atlanta. She had her doctorate degree. She studied health disparities. And 3 weeks postpartum, she collapsed and died from hypertension. I'm not telling you anything new. This has been widely covered in the press. But I did not know her well, but I did have the unfortunate opportunity of talking to lots of people who did know her well, family, friends, and the healthcare team who helped take care of her. And this is devastating for so many people. It's devastating for her daughter, for her parents, for her family, for her friends, and really for the healthcare team who took care of her. Going through something like that is really devastating for everybody. And that's why I really think that Emory can work collaboratively with all the other partners we've heard from today to really help work together to decrease maternal mortality. So some of the things I wanted to talk about that you've already heard about. So you've heard about the Maternal Mortality Review Committee, the committee that was organized or reorganized in 2010 and is led by Drs. Lindsay and Ellis from Emory. This committee reviews all the maternal deaths, as I know this group knows, including determining cause of death, assessing preventability, and making recommendations. I think one area that we can build upon is to really incorporate those social determinants of health that we've been hearing so much about this afternoon, to not just be about what happens when the woman enters the healthcare system, but what happens in the 15, 20, 25 years before she presents pregnant. What are all those other factors that affect health? I also heard a lot of discussion about social determinants of health. I really like the definition. Social determinants of health are the conditions in which people are born, grow, live, work, and play. It's really about how they spend their time and what factors affect their lives and their health. The second area I want to touch upon was the Georgia Perinatal Quality Collaborative, including the AIM bundles of care, which are standardized bundles of care. I think you've heard about them from maybe Dr. Kotke and others previously. 84% of hospitals in North Georgia are now participating in those AIM bundles, and we've incorporated those AIM bundles into our, at Grady and into our hospitals at Emory. And I'm going to come back to that a little bit. You probably have also talked about regional perinatal centers. We have a perinatal center, as you know, at Grady, and these are really specially qualified hospitals which provide a resource center for physicians across the state, and we can really provide the most advanced care for high-risk mothers and their infants. Some of the things I want to talk about that you may not have heard about is that we are now incorporating social determinants of health. As of this week, actually, we've started routinely systematically collecting information from women about all those things that may affect their care: access to food, access to transportation, lots of other issues, safety. And this pilot program is really to identify and understand social determinants of health that impact our patients so that we can intervene. It's not just collecting the information. We're working with community-based partners, such as the Center for Black Women's Wellness and others, to link services specifically tailored to those social determinants of health that we've identified as part of routine prenatal care. The next thing I wanted to talk about was our certified nurse midwifery program. We're the only certified midwifery program in the state. It was founded in 1977. Since they were founded, Emory has trained more than, or close to, 500 midwives. About half stay in Georgia, so a large proportion of the midwives in Georgia were trained at Emory. And currently, it's estimated that midwives attend more than 20% of vaginal deliveries in Georgia. They provide a lot of care.
And Dr. Jameson, I'll be glad to tell the committee and let you know that the Regents have apparently approved the early development of another midwifery program in our state. It's in the very early, so it's not going to give you any competition. And I am asking them to consider trying to be innovative and do something like maybe the part of it be like getting a business degree at Georgia where you can do it on the weekends, and that they would give preference to nurses in rural areas that maybe work 4 12-hour days and then have 3 days off and could do some coursework by on the computer, but would be able to go somewhere for their experience and extensive training that midwives have to make it easier for people that are already living in rural areas. That's where their family is, their home is, and that them get advanced training and still be able to afford it and move forward. So hopefully in the near future we will be training more what I call from the old days nurse midwives.
That's terrific. We're fully supportive of training. We need more midwives. Midwives provide comprehensive, important care, and we would be delighted to work with new programs as they develop. Another thing I wanted to talk about is that others have touched on is this improved remote connections to maternal care. So it starts with the woman. We have Emory has piloted methods whereby people wear iPhone watches or wearable devices to transmit information to the healthcare system. We have done it for cardiovascular disease and EKG transmission. We have a biomedical informatics person who's worked in rural areas in other countries to transmit. He's developed an app that has blood pressure and other monitoring on there that can then be translated. Actually, the app that he's developed doesn't require literacy, so it's all done with pictures, and rural lay midwives touch on the screen with pictures of what is going on, and that information gets transmitted. I think we can certainly develop similar apps for women who do not have good access to health care to connect with their with a provider. And then I think, as touched upon by others, we can also have a referral whereby providers in areas without maybe advanced maternal fetal medicine expertise could connect with institutions like ours where we do have maternal fetal medicine expertise to be able to make those connections through telehealth, through very fancy telehealth, or even more low-tech telephone or Zoom connections on your computer.
Wouldn't it be sort of like the ones I know that Emory, in their neuro department, that when somebody is having a stroke, they can connect with the Emory neurologist on their telephones and show them the scans, and they can tell the local hospitals it would be something on if they're doing the right thing or what to do. And
exactly. So I think there's a lot of opportunity to connect remotely in areas. And then the last thing I wanted to mention was the role of simulation. This gets back to the AIM bundle. Part of the AIM bundle for postpartum hemorrhage, for example, is having a simulation, practicing what happens when you have a postpartum hemorrhage. And this is an area that I think we've really excelled. We've developed what's called MOBS, which is multidisciplinary OB emergency simulation training. And it's multidisciplinary. We do it at Grady. We have a Victoria doll mannequin that bleeds and has a baby and is full size. And basically, once a month, we call out an emergency and say, come to room 3, labor room 3, and everybody from the team comes, anesthesiologists, nurses, residents, medical students, attending physicians, run in the room and see that Victoria is bleeding, and we use some sort of Halloween-type costume blood, and there's blood everywhere. And then you work through as a team to learn how to manage these emergencies. And I think it's very valuable. We've now expanded to other Emory hospitals, but I think there's a real opportunity to have sort of a road show whereby teams could go out in communities that maybe don't see postpartum hemorrhages that frequently and get sort of drill training so that when they do have one, they're very comfortable with how to respond. So I think there's a lot of opportunity to do a lot, and I know, speaking for Emory, we'd be delighted to partner with many of the people we've heard from in the room today to try and decrease maternal mortality. So thank you.
Oh, no, thank you very much. I have a question. It's not whether it was about hemorrhage, and I could probably just ask, somebody that wants to do people that want to do home deliveries were trying to tell me that they carry what would they give in an IM method to stop hemorrhage that you would have?
Oxytocin.
Huh? Methogen? Okay, but if you were really having a severe complication, would that be enough to stop most really dangerous hemorrhages, just having that available?
The easy answer is no. I mean, you really
That's
need
what I
to,
thought,
you
but-
really need to be in a place that can give appropriate medications, do appropriate interventions, and give blood.
Thank you. I mean, I was pretty sure that was the answer, but it was being presented they had that as an emergency thing, and that would basically take care of it until any ambulance or anybody, or they could get them to the hospital or and stuff. Of course, in rural Georgia, some places have one ambulance, and if it's out on a call, then, in your hospital's 70 miles away, that presents a problem. Thank you for answering that question. Okay, you have a question? Good. You're on?
It really is more of a broad question, just because you're the fourth one up here. We've had Morehouse, Mercer, the Medical College of Georgia, and Emory, and I was wondering, is there a way we can encourage either plagiarism or teamwork? I heard about 2 apps, one that may not even require English, which I had never, or any language,
great.
which I thought was an interesting idea. And I know you all have a brand that you're trying to get parents like me to send our kids to your school or whatever. What is there a way to encourage that as the state to where we take a step back and we say, listen, we're all in this. I noticed even in the Albany area, MCG has a huge area, but then what's not shown in there is there's at least 1 or maybe 2 Mercer campuses in Macon and Columbus. Is there a way we can start just encourage the departments? I guess maybe just start with maternal mortality or OB care. Is there a way we can encourage that? Anything we could do at the state level or is that just something you guys have to do?
I agree that we really need to work collaboratively. A lot of the work that I heard about today was work that I was not aware was going on. And I think it's really important that we pool this is much bigger than a brand name, and this is much more important than a brand name. This is about saving mothers' lives and saving mothers. And so I think we really do need to work together. We work very closely with Morehouse. So we work side by side with Morehouse at Grady. On a clinical basis, but some of these larger research efforts are not as well coordinated as I think they should be.
Well, thank you. I hope that's one of the things the study committee is helping us all to learn something about, but thank you.
Dr. Ray.
Thank you for one, but also the idea that there should be collaboration. I think that from a state society standpoint, as the immediate past president for the Georgia OB/GYN Society, it does lend itself to these type of partnerships, and I think we already see some of those partnerships starting to develop, especially with cross-pollination and state organizations like GAP-QC is a perfect example, and Maternal Mortality Review. We are geographically very distinct as well, so it's not about branding because I don't care. For me, it's more about the isolation of being in the East Central region, or you being in Atlanta or Macon or somewhere else. I mean, geographically, it's a challenge, but I think the answer probably lies in entities like the Georgia OB/GYN Society or GAP-QC, for example.
Well, and I have one more question about the hemorrhage packages, the bundles.
Yes.
Somebody came in and said that we have them in a big percentage of the hospitals, and where they're lacking sometimes in the smaller hospitals that do very few deliveries, 3 or 4 a month or something like that, and they're trying to solve other problems and haven't bought into that. But then somebody said they might have 1 or 2 bundles, and that there's a lack of the number of bundles they need. Is that something that you know about, or
Well, Joint Commission is now going to require that at least postpartum hemorrhage and maybe hypertension, that all hospitals have some sort of plan and certain items in that plan. But I think it's a matter of quality, too. I think even if we check the box and say we have the AIM bundle, we need to ensure that really the services are robust.
Okay, and that we have enough of them in case if we're delivering multiple babies and all. Somehow it was that we weren't meeting the numbers or something, even though we had them in so many locations, that we didn't have enough. And is the bundle like just a crash cart?
It's a list of things that you need. So it's a postpartum hemorrhage cart, so that if you have a postpartum hemorrhage, you can quickly get all the medications and the devices that you need to the room quickly. It's having a plan to simulate a postpartum hemorrhage, so you practice. So it's a sort of a checklist of items that your hospital should have in place, and then you have what's called the AIM bundle.
Okay, so it's not a actual, like a surgical tray.
Yes,
It's bundled
no.
together like this. It is a cart or something, so it would just need, okay. Because somehow or other, I'm getting a lot of information everywhere, and haven't worked in OB in several years, and certainly have not seen what all y'all do lately. Wasn't my favorite place to work. I still cross my feet when they do episiotomies and things. So anyway, I haven't exactly kept up with it. So, okay, so it's a cart, and in that case, I don't understand why it would be such a problem for small hospitals
Well,
to have them.
it's sort of a checklist of items that should be in place. So some of them are things like carts, and some of them are activities like practicing OB emergency.
Okay, so that's what it
response.
is. It's not so much you don't have the equipment you need to go on that cart. It's that you haven't had the time to take the training
Yeah, and you
or
haven't-
give specific people. Okay, got it. Am I the only one that didn't get that when they came the last time? Huh? Yeah. I mean, so anyway. Okay, well, now I have it clear. Thank you very much.
Surely.
Are there other questions for Dr. Jameson? Well, thank you for getting somebody to cover for you for delivering babies this afternoon.
Thank you.
What? And like that, and coming over and being the last person and wading through all of it. And thank you to everybody that attended the meeting. We will have another meeting. We're going on with our topics and our in-depth study of the next one. I'd like to focus on really talking about cardiomyopathy. And it's been brought up to me that, you used to have people that were older, had more strokes, and now the strokes are hitting young people at 35. I'd like to bring somebody in that's telling us and what that's doing to women if we're stroking out earlier. And we'll sort of focus in more depth of the different reasons people die and are, listed in the maternal mortality thing. Thank you, Dr. Jameson. Thank you very much.